This year at ASH I was focused on some of the presentations which aims to reduce the toxicity of some of the new therapies which are coming into clinical practice. So the first one was actually a presentation by Christoph Roehlig from Germany, and they had a study called the DaunoDouble study, which looked at two questions. First of all, what's the optimal dose of daunorubicin? And second, do we need one or two induction therapies for optimal outcomes? And their trial had over 800 patients enrolled and randomized to daunorubicin 60 milligram per meter squared or 90 milligram per meter squared, and they found no difference in long-term outcomes. The second question, whether two inductions were better than one, again, they didn't really find any major differences, with 3-year survival rates about 72 to 75% in both arms. And so I think the conclusion from that study is that Dauno 60 milligram per meter squared is sufficient, and that one cycle of induction, if the patient is doing well, is also sufficient. The second study which caught my interest was a presentation by Nigel Russell from the UK group, and they presented results from their AML M19 trial, which is a massive trial, over 1,500 patients enrolled, and they also asked two questions. First of all, is FLAG-idarubicin better than standard daunorubicin-araC? And the second question was whether 2 doses of Gemtuzumab were better than 1. The short answer was they didn't find any benefit from the additional dose of Gemtuzumab with either of the treatment regimens, and overall they didn't find any benefit of FLAG-idarubicin over DA. However, in the nuclear FOSMAN1 mutant subgroup, they did find a benefit for the FLAG-idarubicin regimen, regardless of whether the patients had FLT3 mutation or not. So I think this is a hypothesis-generating piece of data which definitely could be confirmed in a future specific trial on that subject. The third presentation, which aims to reduce toxicity, was a trial led by Dr. Chin Chua from Australia. This was a study that we published in JCO in 2020, which sought to combine venetoclax with intensified chemotherapy in patients older than 60 years of age. So this is an update on that study, now with 69 patients, almost 3 years of median follow-up, and overall the response rate was about 72%. But more interestingly, in the de novo AML subgroup, the response rate was 90%, and the complete remission rate was 64%, with a median survival of 31 months. And this was particularly beneficial for patients with IDH2 and NPM1 mutation. Furthermore, another aspect of this study was that it found that this induction regimen of venetoclax with 5 days of araC and 2 days of idarubicin was extremely well tolerated, with a very low rate of gastrointestinal toxicity, suggesting this could be perhaps an easier regimen to deliver than conventional 7+3. In that study of patients with de novo AML, about half of the patients had a treatment-free remission phase with a median duration of almost 2 years. And so when physicians are considering whether to give an abbreviated approach versus, I guess, continuous Ven/Aza, this looks to be quite attractive in terms of allowing patients to move on with their lives and get treatment done and dusted more quickly. Another presentation which was interesting was a study looking at the role of Ven/Aza and what's the optimal dose schedule. The label indicates that we should use venetoclax for 28 days and azacitidine for 7 days. And this was a study led by Christoph Willensens, where they looked at 82 patients who received only 7 days of venetoclax with azacitidine, so a much shorter exposure to venetoclax. Interestingly, their response rate was still quite impressive, 68%, only with 5 months of follow-up, but at the moment their projected median survival is about 13 months. And so if this is borne out with longer-term follow-up, then it could mean that we could get good outcomes with Ven/Aza using a much shorter schedule, which could be associated with reduced toxicity. The last study that I thought I'd mention, again aiming to try to reduce toxicity to patients, is called the VALDAC study, and this was a study led by Dr. Ing Soo Tiong from Australia. This is a trial which utilised low-dose ARAC in combination with venetoclax, and the aim was to introduce this combination for patients at the time of MRD relapse rather than frank progression. And the study included 42 patients and divided the patients into MRD relapse or low blast relapse, defined by blast counts of between 5 and 15%. In the MRD relapse group, the MRD response rate, defined as a log reduction in MRD, was 70%, which is quite impressive, with an MRD clearance rate of at least 50% and a 2-year survival of almost 70% as well. In the oligoblastic group, which had 5 to 15% blasts, low-dose ARAC plus venetoclax resulted in a response rate of 77%, and the 2-year survival was 44%. So I think collectively these results illustrate that low-dose ARAC plus venetoclax can be a very effective and low toxicity regimen in patients with MRD relapse, with the infection rate only 10% with this study. So I think all of these different studies in intensive as well as non-intensive therapy for patients with AML, I think collectively illustrate that we can use these new drugs, perhaps give less toxicity to patients, but still maintain clinical outcomes. And hopefully all of these studies will have some clinical relevance to our physicians. Thank you.